Well, thank you all for attending our community town hall about the SARS-CoV-2 vaccine. And our goal with this town hall today is really to educate the community from sort of our experience and our perspective about the science behind the COVID vaccine. And if you guys have any questions along the way about the presentation or about the vaccine, the virus itself, or the pandemic, the planning that's been going on, feel free to type your question. We have to have everybody else on mute at the moment, but feel free to type your questions into the chat feature. Anything you type will be seen by the team, everyone who's on the group, unless you want to direct your questions specifically to me. If you don't feel comfortable directing them to the whole group, feel free to private message me in the chat room. This presentation will be recorded, so if you miss anything, we'll share the recording on our website so you can rewatch it or share it with friends or family. And during the presentation, you'll see some of us have our videos on, and you're welcome to turn yours on because we like seeing faces of friends and new acquaintances, but certainly it's not required. And before we go to the presentation, I want to tell you a little bit about Rankin Jordan for those of you who may not know much at all. We are sort of a hidden gem in the community. Rankin Jordan is a 60-bed pediatric bridge hospital, and that means we're the bridge between the acute care setting in the pediatric world, between the acute care setting and home for children with medical complexity, kids who need longer time to recover from serious illnesses, prematurity, accidents and such, than they can get in the acute care setting. We've been at our current location in Maryland Heights for about 16 years now, and carry on a tradition begun in 1941 by our foundress, Mary Rankin Jordan. And if I didn't completely introduce myself, I'm Dr. Nick Holkamp, and I'm the Chief Medical Officer at Rankin Jordan. I would now like to present our presenters. We are really lucky at Rankin Jordan to have a really great team of experts, specifically in this case, in the infection prevention and infectious disease realm. Patrick Hogan is our infection prevention specialist, and has a master of public health and has been working in medicine and research for the past decade, and just came to Rankin Jordan fairly recently. And boy, what great timing with all the work we've had to do recently around COVID, and on top of all the other important issues regarding infection prevention at Rankin Jordan. Duha Al-Zubaidi. Dr. Duha is a physician and a pediatric infectious disease specialist, and she is our infection prevention specialist, infectious disease specialist at Rankin Jordan. She sort of oversees our approach to infectious diseases, and as importantly, the prevention of infectious diseases at Rankin Jordan. And she's been central to our ability to keep our finger on the pulse of what's happening in the community, locally, regionally, and nationally with regard to COVID, and most recently with the rollout of the vaccine. They will share their presentations, and at the end, we'll answer questions you may have. And as I say, feel free to put your question in the chat to everyone, or to me in particular, and we'll pay attention to those and probably have a Q&A session at the end of the presentation. So without further ado, let me introduce Patrick Hogan and Duha Al-Zubaidi.
All right, thank you, Dr. Nick, for the introduction. I'm really glad that you are joining us all today for this really dense education. We have a lot of slides to go through. It's going to be heavy education on COVID vaccines, answering a lot of questions that the community had and our staff had. And so I'm hoping that you'll be able to learn a lot and also educate. We really need to have sort of a campaign to educate about COVID and COVID vaccination, and really reaching out to the community for their health. All right, and so let's talk about some numbers. And so in the world, this is really has been this has affected almost every country. It's a global pandemic. It's one of the largest pandemics that the world has seen in the last 100 years. There's more than 104 million confirmed cases of COVID-19 worldwide. Every single country is affected. There's more than 2.2 million deaths. This is huge. And in the United States, alone, we are nearing about 450 dead Americans since this pandemic started. We can't be numb to these numbers. These are huge numbers, huge number of deaths that we are seeing. If you look at the graph with me, you will notice that the pandemic really started. We started to see numbers early last year, and we recently saw a really big peak right after Halloween. So if you look at October following Halloween, we saw a big peak, and that peak continued right after the holidays. So after the holidays, we saw another big peak. We are finally seeing some numbers and some trends downwards, which is really exciting. But if you look at the peak, it's still pretty high, and we're still very concerned about Corona. In Missouri, we are seeing the same trend. And again, we saw a big peak after the Halloween, and we saw a big peak after the holidays. We actually just had one of the highest deaths just this Tuesday, almost 228 deaths this Tuesday from Corona. And so I know we are all seeing this really optimistic trend downwards. And I think we're all looking forward for that trend to continue. But the deaths usually lag behind, but still the numbers are pretty high. I want to point out, we've all heard about the positivity rate, and the positivity rate comes up many times. What it really means to me is that the higher the positivity rate, the higher there's transmission in the community. Think about it this way. So if you look at the first graph in the St. Louis city, we're in the very high risk zone. That means our positivity rate is around 8%. And down in the county is about 11%. So anything above 5% means that you have high transmission in your community. That's really what it means. So let's talk about Corona. So let's talk about SARS-CoV-2. SARS-CoV-2 is the virus that causes COVID-19. This virus has been studied, and there's so many videos and education on it. It really is just this tiny, tiny particle. It's an RNA virus that's coated with a membrane. This membrane has these spike proteins, which are really important because they've been sort of the focus of all vaccines. So these really little tiny spike proteins all over the membrane help the virus attach to the human cell. And this is how you get infected. So the virus attached to the human cell gets inside through the spike protein. It attaches through an ACE2 receptor. And you also hear about that in the media. And then when that is attached, it goes inside and incorporates into your cells. It instructs your cells, the virus, through that RNA, the genetic material that the virus has, it instructs your cell to start producing more proteins, meaning that's the virus, the components of the virus. So it instructs your own body to make more virus, and then more virus makes more virus, and this is how you get infected. All right, and so I think this is sort of a good introduction on how mRNA vaccines work, right? So you see that spike again, that purple spike, that small, tiny, tiny protein. That protein is the genetic material of that protein is an RNA. So the messenger RNA is incorporated in that lipid coating, and that lipid coating is what's injected into your body. So when you are given the vaccine, that RNA goes inside your body, incorporates into your cells, and instructs your own cell to produce that spike protein. So that RNA quickly degrades, so it doesn't stay alive. It doesn't have a long life. It really just instructs your cell to start producing spike proteins, and when those spike proteins are produced, it spurs an immune response in your body. So your body identifies those and starts producing antibodies. And then you also have your other T cells and memory cells also getting prepared for when you actually get infected with that spike protein and the virus. And so this is how simply mRNA vaccine work. We in the United States, we have 2 mRNA vaccines that have been approved, the Pfizer and the Moderna vaccines. They both have had emergency use authorization early in December. Pfizer was approved in December 11th, followed by Moderna the next week. This was just exciting news for all scientists. This was like breaking news for us as scientists. There's a little bit of a difference between those 2 vaccines. Pfizer vaccine is a 2-dose vaccine, and the Moderna is also a 2-dose. But the Pfizer vaccine has to be given within 21 days, and the Moderna is within 28 days. And then the Pfizer vaccine is also approved for patients 16 years and older. So really at Rankin Jordan, for example, we're very hopeful that we will be able to vaccinate our patients who are 16 years and over. And this is a big deal. And there are pediatric studies going on for each of these vaccines. For example, Pfizer just completed enrollment for the 12 to 15 years old, and Moderna is currently enrolling for the 12 to 17-year-old. So I think there's exciting news for both of these vaccines. This actually maybe is a good time to briefly talk about how vaccines are approved. There are multiple phases, and Patrick will talk more about how quickly we got these vaccines approved. But there are multiple phases, and every vaccine has to go through all these phases. You can't skip a phase. So there's the first preclinical phase that all vaccines go through, and it's really to identify a protein or something in that virus that you think is a good target, like identifying the spike protein, which was a perfect target. And phase 1 trials usually involves a small number of healthy individuals, and the goal for that is to identify safety and immunogenicity. And so you want to make sure in that small number that target, if you inject it, it's safe, and it also allows your body to produce antibodies to that virus. In phase 2, a little bit more of the population, a little bit more variation of the population. So you get the older folks, you focus on them just to make sure that the vaccine is safe, but also produces antibodies in response. Phase 3 is sort of the real deal when you start recruiting so many patients or participants, and then you start doing the placebo and the vaccine group, and then you compare effectiveness and data, which we've all heard about phase 3. And phase 4 is after the vaccine is approved. There's still data being collected about how safe the vaccine is, what sort of side effects, how effective it is in the community. So these are by short. So if you start hearing, we're in phase 1, we're in phase 3, we're in phase 4, just so that you understand. All right, so in the United States or in the world, there are multiple vaccines, but some of the most promising ones that are hopefully going to be approved soon are the Johnson & Johnson, the Novavax, and AstraZeneca. They all have different mechanisms of action. The Novavax really works. The exciting thing, though, about these 3, I want to say, is that the mechanism is not purely new. It's not that like the mRNA, it's not a new technology. We've used these technologies before. So this may be, this may be an advantage that these vaccines carry. The Novavax contains the spike protein and had completed phase 3 in the UK and has shown to be 90% effective, which is just amazing. And phase 3 just started in the US in December. There's a lot of talk about Novavax because there's maybe some more data coming out for its effectiveness against the new variants. It's still a 2-dose. The Johnson & Johnson, on the other hand, which is probably, I'm thinking, going to be the next one available out of those 3. The Johnson & Johnson is really exciting because it's only 1 dose so far. It's close to 70% effective or more. it's a modified adenovirus vector, meaning that instead of that lipid protein, the lipid that sort of holds the mRNA inside it, it's carried inside an adenovirus sort of spaceship. So it's carried inside the adenovirus as a vector so that it can come inside the body. This technology has been used before. And it's exciting because it can be refrigerated in normal temperatures, so it will be more available to the public and easier to store. AstraZeneca is very similar. It's an adenovirus vector vaccine, and it also has already been used in so many countries right now, in more than 20 countries when we looked at the map. So super exciting vaccines on the horizon that are going to be available for the public.
So Dr. Duha described to you all the 2 vaccines that we currently have in use in the United States, and then the 3 that are kind of in the pipeline to hopefully be in use soon. And we just wanted to let everyone know that there are actually 9 approved vaccines if you look around the globe. So these vaccines are being dosed to patients in places other than the United States. And there are 58 more in development. So we really do have a lot of hopefully good vaccines coming that will get rid of some of these supply chain issues that we have. 9 of those vaccines in development are actually already in phase 3. So because this is a global pandemic, we won't really end until we take care of it across all of the countries of the world. So speaking of vaccines, how are we doing? So overall, 8% of Americans have received their first dose of the vaccine, one of those 2 mRNA vaccines, and 2% of those people have actually received both doses. In Missouri, that accounts to 427,000 Missourians receiving at least 1 dose. We're struggling a little bit. We're at about 6%, which actually puts us last in the United States as far as the states go for the proportion of our citizens getting vaccinated so far. The dosing is increasing. We're actually up to 1.3 million average doses a day in America, which puts us on track, if you look at the graph on the right, to get to 50% of Americans dosed by July 2nd, if we keep it at 1.3 million per day pace. If we speed that up, that timeline could get shortened. If we run into supply issues, or if we run into skeptical public who isn't maybe willing to take it, that timeline could get increased. So, a lot of people probably want the vaccine, they can't get it. So we just wanted to remind people about the phases. So in Missouri, we have phase 1A, which was the healthcare workers and nursing home residents who have all hopefully gotten through the line. And then we're already into phase 1B, tiers 1 and 2, which is first responders, law enforcement, older Americans over 65, and then other adults that might have chronic health conditions like obesity and cancer and other chronic diseases. And then the next part of phase 1B that should hopefully start soon will be tier 3, and that will be educators, childcare staff, and people who work in certain essential societal sectors like communications, energy, government, IT, things like that. So at Rankin Jordan, we're really excited to report that 100% of our medical team decided to take the vaccine. We had tremendous uptake across the hospital, but when we asked them at team-wide, they emphasized their belief in science and their desire to protect themselves, their patients, their colleagues, and their loved ones, and to get this pandemic to come to an end. And we're hoping at Rankin Jordan, through events like this, to be part of the solution and encourage other people to trust science and take the vaccine. So across the hospital, we had about 75% of our employees accept the vaccination. We were grateful to get a generous allotment of the Mercy vaccine, and they shared with us. So after we offered it to our employees, we actually decided to do a survey to find out kind of why some people decided not to take it, because we thought that would be helpful to learn, and then hopefully we could share information back with them. So we were able to get a lot of helpful information about their motivations and fears and concerns, and the rest of the presentation will kind of be guided by what their feedback was. So most of those people decided not to take it due to long-term safety concerns. A lot of them thought it was developed too quickly. A few doubted the effectiveness. Some just lacked knowledge about the vaccine, and then pregnancy, breastfeeding, and fertility concerns were pretty common as well. So I think the first thing to really decide is the COVID vaccine effective? And so Dr. Nick says it is. So let's see if he's right. So we wanted to combine phase 3 clinical trial results from those 2 mRNA vaccines we talked about because they were so similar, the trials and the drugs themselves. And if you look at the 2 charts, I mean, the results are almost identical. And so if you combine those 2 trials, there were 74,000 participants. Half of those people received a placebo, half of them received the actual vaccine. And then after the follow-up from those participants, 366 of those 74,000 participants got a confirmed case of COVID-19. And when you break that down by what they received, what arm they were in, 347 of the people that got COVID were in the placebo group, and just 19 of the people who got COVID were in the vaccine group. And so that's kind of where you get the math that gets you that 95% effective number that you hear about on the news. And then just in addition to the vaccine being 95% effective in preventing disease, it was almost 100% effective in preventing severe cases of COVID. So it's more than just you won't get COVID, you also won't get a severe case, hospitalization, or death. So the second most important question that people had was, this was made really fast, and that just made people really nervous. So we have, we kind of want to go through a bunch of reasons why the speed should not be a cause for concern, but rather thought of as a remarkable achievement. So I'm going to kind of go through a bunch of those. So first we had a head start. So much of the legwork for the vaccine development was started as late as 30 years ago in the 90s when scientists started studying mRNA vaccine technology. Sometimes if a virus or a pandemic kind of fades away, goes away for other reasons, the funding and the focus loses steam, but we were still able to use some preclinical and academic research from back then to that would normally take years to give us a head start on this vaccine. So also we had unprecedented funding. So the money and manpower thrown at the development and manufacturing of this vaccine is really extraordinary. Typically funding would be delayed or inconsistent for a new drug, but this is, and that's understandable as priorities are really diverse in normal time. But during this pandemic, priorities have obviously been really clear and focused. Everyone's focused on ending this pandemic because of what it's done to human life, but also the economies of the world. So that's why we had such an incredible worldwide collaboration. So governmental agencies, academia, nonprofit organizations, pharmaceutical companies, hundreds of thousands of study volunteers and more worked together to prioritize the speedy development of these vaccines. And I think one of the best examples of that is that the virus was first recognized in December of 2019, as y'all remember. And by January 10th of 2020, so just a few weeks later, we already had the first SARS-CoV-2 genome sequence released online to the public so that people could really all work on this together. So then we also benefited from early production. Some of these manufacturers of the vaccines took financial risks that they might not normally take, where they decided that rather than waiting for approval, they would start making their drug candidates early, kind of with the hope that they would be approved. And then once they did get the approvals, they would have the drug ready to go on day one. There's also been major technological advancements just in vaccine technology. So advancements in RNA biology and chemistry and delivery systems and manufacturing when compared to historical vaccines. And, we don't doubt those technological advancements with things like our cell phones, and we see how quickly things change. And so I think scientific technology should be looked at no differently. And then expedited bureaucracy helped as well. So new drugs usually run into slow regulatory processes. Companies submit data and then weeks go by or months go by before it gets looked at. And so in this case, just like everything else, we kind of got rid of all those barriers to moving the process along. But then most importantly, efforts to speed vaccine development did not sacrifice scientific standards, integrity of the vaccine review process, or safety. So we had, like I said, we had 74,000 participants just in those 2 trials and hundreds of thousands more in all the other trials. And historically, we've approved vaccines with less participants. So the most common concern was long-term safety. So we have to admit, no medicine, no vaccine is 100% safe. We've obviously only had only months, not years of follow-up for these vaccines. However, historically, with vaccines, the longest effects really take place are within 40 days. We don't usually see effects after that. And so both the EUAs that were granted for these two vaccines weren't granted until 60 days after the second dose. So we really would have seen long-term side effects. They're really rare with vaccines, and we don't expect to have them with this one. But what we do know about the vaccine that makes it very unlikely is that first, there were simple ingredients. So we have the mRNA that Dr. Duha talked about, and it's cased in lipids that help get it to your cells. There's not much else in it. You can read about the ingredients online. There's only eight or nine things in each one. And there's no live virus in the vaccine. You cannot get COVID from the vaccine. And the mRNA doesn't enter the nucleus of your cells and can't alter your DNA. And we know this because the mRNA would just degrade immediately if it wasn't protected by that lipid. And so it really isn't going to stick around and cause any problems for you. But the risks of long-term complications from COVID really can cause problems for you. So when we're weighing that risk benefit between long-term safety of a vaccine and long-term effects of COVID disease, it's far worse with the disease. So heart failure, lung disease, brain fog, 35% of COVID cases actually cause some sort of long haul symptoms. So that's 14 to 21 days after testing positive. We often see coughing, chest tightness, shortness of breath, chronic fatigue. Even 20% of young people have these long haul symptoms. And so we have to kind of weigh those real scary long-term effects from the disease with these imagined theoretical long-term safety effects. So short-term side effects are a little bit of a different story because these are not uncommon. Most of these effects do occur within 24 to 48 hours, but then you feel great. Sore arm is probably the main one that people get, but headaches, body aches, chills, fever, they're definitely not uncommon. And they're more likely after that second dose. The good news is that that's actually a sign that your immune system is working. So we do have monitoring for these events just to make sure that they stay within kind of parameters that we're comfortable with. So you have to be monitored for 15 minutes after you get your vaccine. And then there's these two systems, one called VAERS, which is Vaccine Adverse Event Reporting System from the Health and Human Services. And then there's an app called vSafe, which you can download and you should download after you get the vaccine, which is a vaccination health tracker app we have some data on that. So this just helps authorities make sure that, we aren't seeing any anomalies or, certain people getting something that they shouldn't be getting. And so just the most common reactogenicity we see from this vaccine is pain. That's that arm soreness we talked about. And then you can kind of see across the doses that Pfizer dose 2 is really more likely to give you some of those tougher ones like headache and fatigue. But like we said, they usually go away within a day or two. And just to summarize on safety data, so 26 million Americans have gotten COVID disease and 450,000 of them have died. 30 million Americans have now gotten the COVID-19 vaccine, and to this point, no one has died from the vaccine. So rumors you might have heard about on the internet that we wanted to address. So, there's some conspiracy theories out there. And so we just thought we should just say some of these things bluntly. This is all from the Missouri Department of Health and Senior Services. And they do a good job of, if you go to their website, of just taking each one of these and just saying, we have to move on from some of these silly things that we hear about on social media. So there's no chip or tracking device in the vaccine. Bill Gates is not collecting your data. COVID and the vaccine are definitely not a hoax, and 5G has nothing to do with this. So we just encourage you to ask yourself a couple questions if you hear any of these things or hear other people running with some of these conspiracy theories. It's just, where did you get your information? What do trusted members of the medical community think about some of these things? And just ask your doctor or go to a website like Missouri Department of Health and Senior Services rather than kind of running with some of these if they seem like they might be a conspiracy.
All right. And so, all of these questions, did actually come from our staff members, and I'm hoping that they are really answering some of the things that you are wondering about, since the next phase really is getting the public vaccinated. And so I'm sure you're starting to ask your questions: which vaccine am I going to get? What side effects? What should I expect after my first dose? What am I going to expect after my second dose? They always say my second dose is harder. Do I need to do this before? And so I'm hoping that this is a place where you can come back and listen or look at the slides for some of these questions. Some of the questions that a lot of our staff asked when we had the vaccine offered to us is that what if I have allergies? What if I'm allergic to food? Or what if I had an anaphylactic reaction to flu vaccine and no longer can take flu vaccine? And so the good news is that the CDC has come up with a very clear statement that there's no contraindication to this vaccine other than if you had an anaphylactic reaction or a severe allergic reaction to a component of COVID-19 vaccine. So since the components are very small, there's no cross reaction with eggs or latex. We've had a lot of vaccines that did in the past, but this specifically does not. And so we're talking about the Pfizer and the Moderna right now, since they are available. And so if you've had a reaction to the PEG or the polyethylene glycol, that's one of the components, definitely, you have to consider talking to your doctor and do not take the vaccine. Initially, when the vaccine was first offered, there were millions and millions of people taking the vaccine, and the allergic reactions or the anaphylactic reactions were really published everywhere as if it was very common. In fact, I want to say it's not common. And so now, after giving 10 million vaccines of Pfizer, we've had 50 anaphylaxis cases, which means like 5 per million doses administered. We've had a reaction that was severe enough that needed intervention. Same for Moderna. So pretty low numbers compared. They're really sort of coming. The more vaccine you're giving, the rate sort of is decreasing and almost becoming comparable to other vaccines. It was just high because we didn't give enough to know what the true rate is. And I think the rate is still going to continue to go down. An important thing to note that no one died from these, as far as we know, as far as the CDC has reported, no one died from these anaphylaxis reactions. They were all reversible with an EpiPen or Benadryl at the site of vaccines. If you had an anaphylactic reaction in the past, it is recommended that you wait, since your body may be a little bit more susceptible for allergies. You may want to wait more than 15 minutes, 30 minutes. The CDC met last week, was January 27, and when we read their minutes and sort of went through the data that they presented, it sounded like almost all anaphylactic reactions occurred within the first 30 minutes. So almost all of them, the highest peak occurred in the first 15 minutes, and then a little bit more trickled within the 30 minutes, and very rarely they occur after that. And so I think all these things should be reassuring once you actually go and get the vaccine. Some people have anxiety going to get the vaccine, and so some choose to actually wait for 30 minutes, and that's totally fine. I did, and so I think it's okay to wait and just make sure that you feel safe and taken care of before you go.
Hey, Dua, we are going to have question and answers at the end, but one question relative to that topic comes, what about seafood allergies?
Yes, so the CDC really says that if you are allergic to food, this is not a contraindication. There's no component of seafood or allergies, but I know that people who have seafood allergies often have severe anaphylactic reactions, even to just smelling seafood. And so it is definitely recommended that you wait longer in that center that you're taking the vaccine. So wait for 30 minutes. If you feel comfortable, you can leave. If you don't, wait 45 minutes. The CDC have not reported any of these anaphylactic reactions occurring after 45 minutes. And so I would say, it's reversible. If you have an EpiPen, have that EpiPen with you. It's definitely, there's definite treatment for this. All right, so one other question that we had from a lot of our employees is that, what's your take on pregnancy and the vaccine? And I think we usually combine breastfeeding women and pregnant, although it doesn't seem the same. Pregnant women are number one, if you think about it, the CDC highlighted pregnant women as being one of the highest groups to get really sick of corona. And so to a point that, if we have a pregnant woman working here, that pregnant woman is not allowed to take care of COVID patient, even though we have all the protection gear. They're not allowed to take care of COVID patients, at least at Rankin Jordan. And so this highlights that COVID infection is not simple. They can develop severe disease. They can have abortions. It can affect their fetus. And so I want to make sure that there is risk. So once a person who's pregnant is trying to think about that, think about your risks. Talk to your OB. I think one of the best things that I've heard is that, I talked to my OB and I think we've decided that I should not take the vaccine. Or I talked to my OB and, the risks versus the benefits are better. I mean, I think I need to take the vaccine because my risk is higher. And so these are sort of the conversations. If you're able to social distance, stay home, not get exposed to COVID, then maybe the vaccine is not right for you right now. Maybe you need to wait for more data. The thing about the trial with Pfizer and Moderna is that it was not part of the inclusion criteria. So if you were pregnant, you were not included in the study. About 20 20 women became pregnant during Pfizer vaccine, and there were no reported side effects. So some people got pregnant during the trial, but they were not enrolled while they were pregnant. What other thoughts? One other thought about breastfeeding is that I've heard a lot of people saying, I want to take the vaccine right now so I can pass the antibodies to my baby. And so there are really some pros and cons. It really depends on how you are thinking about it, what you think your risk is, what you're willing to take. There is exciting news is that, the VSafe app that Patrick Hogan talked about, there are about 227 women so far up to date, up until January 27th, that have already enrolled and under surveillance. So we have not heard of any red flags saying that it's really harmful for the fetus. There's really no scientific reason why it would be harmful for the fetus or the mother. And initially there was a lot of talk about infertility, and I think that the science tried to explain as much as possible. There was some confusion between the spike protein, that little protein I talked about, and a protein that's present in the placenta. They actually are not similar. They're not the same. I think some anti-vaxxers try to say that the antibody that you produce to the spike protein is going to attack your placenta. I just don't know where that comes from and how true this is. Some women, like I said, became pregnant while in the trial at Pfizer. And then the golden question, right? The golden question right now: can vaccinated people spread COVID-19? I think we don't know. We really don't know the answer, and I sort of wish we do. And I'm hoping that the studies are looking into asymptomatic carrier, right? That's basically what it is. You're protected from severe, moderate disease with all these trials, but are you protected from being an asymptomatic carrier and transmitting it to others? Some things that the scientists, first of all, the stand that they are taking is that probably if you're not developing severe disease, you're probably not transmitting disease. And the reason is that the way you transmit disease is that you have a lot of virus in your body. And so it makes sense that if you are infected, then you have a lot of virus in your body and you're symptomatic, and that you're transmitting it. But if the vaccine prevents symptomatic infection, it makes sense that you won't have enough virus to transmit it. We don't know. I guess the bottom line is we don't know. Hopefully there's going to be more data that helps people feel more comfortable that they, are not asymptomatic carriers. We had a lot of questions about, am I going to take this vaccine next year too? Again, like influenza. And unfortunately, the vaccine just started, so we don't know how long the immunity lasts. There's lots of data coming out that it's lasting for 120 days, 155, 240. What we know is that your antibody response from taking the vaccine is much stronger than when you get an actual natural COVID-19 infection. So especially if you had mild COVID-19 infection, you probably are not developing strong antibodies that are lasting for 90 days or 120 days. And so we think that the antibody response to this vaccine is going to be strong. And there's other components. I don't want people to forget that there's usually other components of your immune system playing a big role in preventing disease, like your memory B cells and your T cells. So I want to make sure that we don't have an answer, but we think it's so far looking really good and strong. And now to the most sort of sad topic, which is the variants, right? So we are all hearing about new variants, and it's pretty concerning for all scientists right now, especially the last variant. So all viruses mutate, and that's something it's not new. We know that. We study that. All viruses mutate. It's just when the mutations are a lot or are affecting a target that the vaccine has worked on is when we really pay a lot of attention to. So, for example, the UK variant, which was first identified last year and now is sort of prevalent in the UK, the B117, is definitely now reported in the US. And the more sequencing we do with the virus, the more we will find of these variants. The other, a little bit more concerning, the South African variant is the B1351. There's 3 cases reported when we pulled the slide, but there's many more reported. And the more sequencing we do, the more we identify more of these variants. And the P1 is the Brazilian variant. Word about these variants is that so far, those variants are thought to be more transmissible. So they are going to be spreading more and causing more an increasing number of infections. So does that mean that they're more deadly? I have not heard any data about that. So I don't think they're more deadly. In fact, scientists compare the symptoms that you would have from your regular variant to the other variants, and the symptoms can be exactly the same. But we are hearing about more cases, and maybe more cases are sounding like more deaths. And so this could be one thing to pay attention to. It sounds like also some exciting news, but still very prelim, is that those vaccines can be modified to include these variants. And some actually are already showing some effectiveness against this variant. But I think there's a lot of science that needs to go into this to make sure that we know a lot more about these variants. All right.
Yeah,
sorry, Patrick, go ahead.
Yeah, so one of the big questions people have is, if they already had COVID, do they still need to get vaccinated? And then if they do, when do they need to? So the easy answer is just yes, you should still get vaccinated. Because part of the nuance there is that, if you haven't had a very harsh infection, you had a more mild infection, then you might not have amounted quite as big of an immune response to your infection. And so your antibodies might not last as long. Maybe about 10% of people who've recovered from COVID kind of have that weak antibody that we need. So once your active infection is over, it's safe to go get vaccinated. It's just highly unlikely that that's going to happen in those first 90 days. And so right now, while vaccines are scarce, we're still prioritizing people who haven't had COVID in the last 90 days that don't have any natural immunity. So I think one of the hardest things is COVID-19 transmission in schools. So, it's much harder to study and control variables when we're talking about kids in schools than it is, in these vaccine trials. And so we just don't know that much. However, a study did come out recently from the CDC where they looked at 17 schools in rural Wisconsin that were open, that implemented a bunch of measures to limit spread, ones you've all probably been doing for a long time now, but they made sure the kids wore masks. It looks like 92% of students were using masks, according to teacher reports. They tried to establish groups of kids, so cohorting kids into groups of 11 to 20. They also tried to maintain 6 feet of distance when possible, and then they quarantined kids after exposures. And so over a 13-week period, they only saw 7 cases of known, like at school, transmission of COVID. And all of those happened in students. There were no staff members who got COVID at school. So they also saw that the incidence here, that's 7 cases in those 13 weeks, was much lower than in the county overall. So the take home was sort of that schools can be open safely as long as we use these mitigation measures. And I guess the caveat to that is just that, if schools that aren't in a rural area, schools that maybe don't have the resources to make sure that all these measures are in place, like cohorting isn't probably not simple. We know that here from the hospital, and quarantining after exposures. And there's a ton of work that goes into that. And so schools that have less resources might be less likely to be able to kind of provide this level of safety for their kids. So we just have a lot more to learn about this complicated issue. So when will the rest of everyone else get vaccinated? We wish we knew. We wish Missouri wasn't kind of going so slow, but we do have all these resources for you. So you can click on these links, go to the web pages of these cities and county health departments and these hospital systems, and you can pre-register on a lot of them for the vaccine. You don't know when you're going to get called back at all. A lot of it has to do with your age and what phase we're in. But there's no harm in getting on more than one list. I do know people who've pre-registered on these lists and actually gotten phone calls and gotten their vaccine. So it is happening, however slowly. So then just kind of some final questions. So do we need to keep wearing our masks after vaccination? Dr. Duha kind of talked about this a bit, but because, the vaccines are looking really good, but because they're not 100% effective, because of these new strains that we're talking about, because of this potential for asymptomatic carriage of vaccinated people, we do think you still need to keep wearing your masks and kind of doing all these other mitigation measures like physical distancing and staying home when you can. Because most importantly, Dr. Fauci and the CDC are continuing to recommend strict precautions even for vaccinated people. Partially because we don't know who's vaccinated. You don't walk around with your card out or anything. So we don't know who should have a mask on, who shouldn't. And then if vaccinated people in general started lifting their guard, that would certainly make it easier for unvaccinated people to lift their guard, which we wouldn't want. And so when will masks go away? Dr. Fauci predicts maybe by the fall, maybe later, but it depends entirely on how many people do their part, take the vaccine, and also obviously on how many are available, if people can really get it. And then some of these other questions like, will the vaccine be annual or will masks be seasonal? We just really don't have answers to yet. So in summary, we just want to point out vaccines don't save lives. As exciting as they are, vaccinations do. So we have to get these shots in people's arms. The vaccine is the most effective tool you have to protect yourself, the people you love, and to bring this pandemic to an end. And just to stay vigilant, maintain your distance, continue to wear the masks, and be patient. We hopefully have an end in sight here. So if you ever have questions, you can reach out to Dr. Duha and I. Here's our contact information, and this is just a bunch of the sources that we use to look up a lot of this information for you. We'll kick it back to Dr. Nick.
Wow, thank you very much, Patrick and Duha. For those of you tuned into this town hall, you can see why I'm so proud and grateful and really fortunate Rankin Jordan is to have such great talent and at such a crucial time in our history. I can share a little bit before we wrap up on what we're doing still at Rankin Jordan to mitigate spread. We've had a very good track record. We've had very low occurrence among staff. We've had a number of staff have COVID through community acquisition. And in the entire pandemic, we've had a total of 1 inpatient who turned positive for the infection, but was asymptomatic and was found on a routine screen rather than symptomatic, and no patient-to-patient spread within the hospital. Our goal was to immunize as many staff members as possible. As Patrick mentioned, we were able to get about 75% of our staff vaccinated, and we're hopeful that as soon as vaccine comes available, since our patient population is high risk, that all the kids over 16 and over will get to be vaccinated as well. We are continuing very rigorous hand hygiene, mask wearing, social distancing. We screen all visitors. We ask staff to continue to self-screen, and that's been very effective for us throughout the pandemic. I don't see and haven't seen, other than the one I mentioned earlier, questions in the chat. We're still open for questions. If you have those now, put those through. Before wrapping up, again, I'd just like to thank our presenters and thank all of you for attending. Hopefully this was worthwhile. As we mentioned, the program has been recorded. It will be available at rankinjordan.org/coronavirus, obviously. So you can look for that on our website. There it is. The presentation will be shared rankinjordan.org/coronavirus. So again, one more request for questions before we close things down, or anybody on our panel have any final thoughts to share?
I wanted to ask, people in the community who are listening to really be empowered to educate, instead of people around you who want information, be empowered to educate, be empowered to take this presentation or these information and resources. I think this is now handed off to the community. We want you to help us end this pandemic. Healthcare workers sort of are done with their role. We are trying to vaccinate. We've gotten vaccinated. We're trying to take care of our patients. Now it's your chance to help with this pandemic. So feel free to ask us questions, take all these resources and help educate your community.
Well, thank you all very much for attending and participating, and find us online at rankinjordan.org. Thank you very much, y'all. Oh, wait a minute. The numbers shared for the rural school in Wisconsin, are there any similar for schools? That's been one of the criticisms I've heard about the study is, well, that doesn't apply. It's not a big city. It's not dense, and there's limited class size and such. Either of you two want to take that one?
Unfortunately, I haven't heard of any studies in urban schools. That was one of the things I tried to mention about generalizability. We can't take that data and say, open your school in an inner city where the rates of COVID are probably completely different and the ability to social distance is different, all that stuff. That's why I think the take home from that is this was good news, but we need more information.
I can say from personal experience, my daughter's school, there's that same controversy as we've heard nationwide. Well, students and parents want to go back to school, but the staff appropriately are anxious that asymptomatic or kids who might get exposed might bring it into the school and expose the staff. And at the end of the day, it really is up to how well the school administrators can impose and enforce the preventive measures. But the challenge is you can't make people come to school and work if they don't feel comfortable and safe. So I think it's really going to take getting more people vaccinated before folks feel comfortable generally to reinitiate in-class training, in-class schooling. That was the last question. Again, thank you for participating, and we'll see you online.